Okay, so hello and welcome to day 5 of Clinical Audit Awareness Week 25. So it's the final lunch and learn of the week with today's topic on efficiencies and how we can effectively utilise clinical audit to drive that evidence-based improvement and to reshape the health and care to support people to live well for longer, both effectively and efficiently. So my name's Vicky Patel, Chair of NQICAN and Clinical Effectiveness Manager at the Rotherham NHS Foundation Trust and your Chair for today's lunch and learn. Little bit of housekeeping then before we kick off. So the event's being recorded. Would be lovely to see your cameras on, but obviously if you don't want to be recorded, feel free to turn them off. You'll note that your mics have been muted. There will be the opportunity to ask questions, and at that point we'll unmute you so that you can actually raise your question to the speakers. Q&A functions live, so please do also utilise this to post a question or actually add a comment relevant to today's lunch and learn. So if we can move to the next slide, please. Okay, you can see that we've held daily our lunch and learns as part of Clinical Audit Awareness Week 25. And it's just a reminder at this point, as we're on day 5 and our last lunch and learn, that actually you can access the recordings and slide packs from previous events held this week over on the HQIP web pages and on the NQICAN Future NHS workspace, both of which we'll put links into the Q&A for you should this be your first event that you're attending. So if we move to the next slide, then we'll just have a quick look at today's agenda before we move on. So we're going to start with an introduction and a recap on last year's takeaways, just to set where your thoughts are at around efficiencies. We are going to round up the week itself, so you're going to hear some key points from both myself and also Chris Gush, the CEO of HQIP, around efficiencies. And then today's speaker is Dr. Teresa Barnes, the clinical lead at the Royal College of Physicians and also Associate Medical Director and consultant at the Countess of Chester Hospital. Now, Teresa's unable to join us today at this time, but she's kindly recorded us the information that she's actually going to share with us. Had she been here in person, it's that same information. So she's sharing it with us today as an important piece of work that the ICP have led on around transforming outpatient services. So really also pleased to let you know that the RCP and NQICAN have also agreed to work together to look at how we can all take this work forward in our own organisations and systems when we're responding to the NHS review and obviously the 10-year health plan. We'll have that opportunity to ask questions alongside taking away any further questions that you'd also like us to send on to Teresa directly for responses that we can publish, and Teresa has kindly provided her direct email address as well should you want to post questions directly to her. Really excited to say that we're going to have the Clinical Audit Hero Award winner announced for efficiencies, and they're going to present, and then we're going to sum up the week and undertake an interactive evaluation with you on screen before we finally, as always, challenge you to take away some key tasks, challenges back to your own organisation. So if we could move on, we're going to just have a quick reflection on the takeaways from last year's Lunch and Learn on efficiency. So this is what our colleagues said that joined us for the event last year. And whilst you're just having a look at those on screen, I am going to touch on the challenges that we set you last year that actually when we re-looked at these this year, they're all still really relevant for you. So we tasked you with looking at building that shared commitment for each project that you're working on, regardless of whether it's a national or local, that shared purpose with your stakeholders as those conveners and enablers with that influence and that persuasion that we can have. We talked about you collaborating with your system partners, that clinical audit and QI teams, that collaborative working together with that improvement expertise, and also with your partner organisations within your systems and pathways. We touched on that wider spread and scale of innovation and technologies to really have that impact on improving health outcomes and addressing equity and access for all. And then we finally focused on those new care models, improving how care is actually delivered to meet need and demand. All still relevant. So if we move on then, we're going to just look at the fact that we tasked you last year with that bold and ambitious. This year, big focus on that value and impact, that importance of measuring outcomes, return on investment, and that long-term sustainability. So we know from the NHS review published last year, it focused on what our challenges were within our systems and that we needed that vision for reform. highlighted here some of those key points for you around emphasising that better use of data and analytics to drive that performance and accountability as well across the NHS, highlighting where we've got regional disparities and calls for standardising our care pathways and looking at that equity and how we're actually delivering our services. There was a lot around the lack of patient and staff engagement and urging for that stronger role for patient experience in shaping services, and then pushing for that digital transformation, including electronic health records, artificial intelligence, and systems to improve efficiency. And then finally, that call for integrated care models, reduction in waiting times, and more preventative community-based care. So let's have a look at a couple of those in a little bit more detail than just in terms of efficiencies today. So if we just move on to the next slide then. 3 big shifts for first around that hospital to community care, really. Technology enabling more care to be delivered at home or in the community through that remote monitoring, virtual wards and that telehealth. Virtual wards for frail and elderly patients. It's a great example of that shift from hospital to community care using technology. We've got elderly and vulnerable patients often facing hospital admissions for conditions that could actually be managed at home with the right support if you think about falls, infections or chronic illness flare-ups. And now with virtual ward, patients are discharged early or they can actually avoid hospital admission altogether. You've got that step up as well as that step down. And obviously with virtual ward patients, they can be discharged early, they are monitored remotely, they've got those check-ins virtually, and they've got 24/7 clinical oversight using those digital dashboards. So real impact, real world impact. And then this analog to digital here, this digital first, NHS means using artificial intelligence, those electronic health records that we've already mentioned, and several NHS trusts across England are already using or piloting AI that's powered around early warning systems for conditions like sepsis. So then treating illness to preventing it, then this was a big one in the review. Then it's looking at how we can use AI then to actually identify risks early. It enables that preventative intervention that reduces long-term costs, but does also improve that quality of life. So just quickly looking at an example, say patients with chronic heart failure often experience worsening symptoms that lead to emergency hospital admissions. Those can be costly and obviously they can also be life-threatening. You look at some of our tech that we're now introducing along with artificial intelligence, like your smartwatches or your chest patches, that continuously monitor those vital signs such as your heart rate, your oxygen saturation levels, your respiratory rate. They can all help to support the patient, and actually they are linked up to real-time monitoring. They detect those subtle changes that might indicate deterioration and prevent hospital admissions, improve your quality of life, and it reduces your cost and actually empowers your patient more with control over their health. So just moving on to the next slide then, we were just going to have a quick look then. So second area really to raise here, and now the focus on that timely, integrated and person-centred services going forward. So thinking about the integrated care models, especially around coordinated care for long-term conditions, digital innovation around virtual wards and remote monitoring, which we've literally just touched on that previous slide, preventative health around your frailty and your falls prevention services, and what ICSs are now doing in terms of deploying those community-based frailty teams to assess and support older adults at risk of falls or hospitalisation so that we can keep them out there in the community. And then finally here, modernising the outpatient care, transforming outpatient services, which aligns with some of Lord Darcy's recommendations around redesigning care pathways for efficiency and patient convenience. Transforming outpatient care needs to be timely, integrated and person-centred. But I'm going to ask you to hold that thought there about outpatient services, because I'm now going to hand over to Chris Gush, HQIP CEO, to talk about Clinical Audit Awareness Week and efficiencies from the perspective of HQIP, and then we'll come back to have that focus on outpatients. So over to you, Chris.
Thanks, Vicky, and good afternoon all. Thanks for being here. Whilst I don't work on the front line, we all know the pressures the NHS is facing right now, and I do spend a lot of time listening to those who do. The theme of my short talk today is quite simple. How do we make smart, focused decisions when resources are tight? Around that theme of efficiencies. And while National Clinical Audit is a tool, we cannot afford to ignore. So, as I said, I don't think I need to tell you that demand is rising, workforce is under pressure, and budgets are incredibly limited. So, we have to ask ourselves, what are we using to guide our decisions? What gives us the confidence that our investments and our clinical strategies are going to lead to better care and better outcomes? And from an HQIP point of view, in the work that we do, this is where clinical audit steps in. I'm talking about audit as a strategic asset here, a lens that shows us what works, what doesn't, and where we need to focus. At HQIP, we commission the National Clinical Audit and Patient Outcomes Programme on behalf of NHS England. Over 40 national audits and clinical outcome reviews. It's delivered by clinical experts covering everything from cancer and trauma to joint replacements and maternal health. And they're delivered by our providers, many Royal Colleges, universities, that work incredibly hard with us to do that. This isn't abstract data. This is lived experience of the NHS, captured and analysed in a way that's intended to drive improvement. I'm going to try and give a few examples here of how that can support decisions. The National Hip Fracture Database is one of our largest audits. It captures over 70,000 cases a year. And what we've learned is clear. Speed matters. The quicker patients get surgery, the quicker they recover. But this audit also flags where delays are happening and the consequences: more complications, higher costs, poorer outcomes. And now we can think about the National Joint Registry, which is hosted by HQIP and run by the NJR, and that's over 4 million records. It's a huge powerhouse of data on implant performance and surgical outcomes, and surgeons use it to reflect on their practice. Trusts use it to inform procurement, and commissioners use it to see value. And when I'm talking about procurement, it's which joint to purchase and which one is performing best and gives that value. And even a small improvement in revision rates translates into a serious saving and better patient experience. Embrace is different. It deals with maternal and paternal deaths, incredibly sensitive work, and it really matters. The audit has directly influenced national maternity policy, but it also shows us where care is falling short and where it must improve. And again, it really is a reminder that audit isn't just about numbers, it's about stories, it's about lives, and it's about system level learning. And then there's a national lung cancer audit. This one highlights variations in care and access, who gets diagnosed early, who receives curative treatment, and unfortunately who doesn't. And in a condition with such high mortality rates, this kind of data isn't just helpful, it really is essential. So what's my takeaway here? Well, it's whether you're in a trust working at a system level or involved in commissioning, this intelligence is there for you to use. Audit cuts across silos, it brings clarity, and in current climate, that's what we need more of. So our job at HQIP is to keep improving this work. This means making audit data more easier to access, making findings more usable, and making sure that learning translates into change. Many of you influence policy, commissioning, regulation, and research. And so what can your role be? Well, it's a big one. Audit data feeds into that decision-making about funding, workforce, safety, and transformation. And it increasingly needs to be joined up with other data sets from EPRs, PROMs, incident management. And you can help integrate that, advocate for that audit, or just ask the right questions. You're driving real value into that system. And if you're not already using audit to help guide your decisions, whether it's about priorities, workforce, or investment, you're leaving value on the table. Clinical audit isn't just a report to file away, it's a tool for action. And HQIP are here to help. Contact us. We're happy to help wherever we can, provide support. Thank you very much for your time.
Oh, lovely. Thanks, Chris. So I think then we'll move on to the next slide then, please, Louise. And I think we'll be at the point then where actually we'll move on, and we will now start to play Dr. Risa Barnes' recording from the RCP around the really important piece of work around prescription for outpatients. So I'll let you then move to the next slide and play the video then.
Thank you for inviting me to speak to you today about our prescription for outpatients, reimagining planned specialist care. I'm sorry that I can't be with you in person today, but I'm very happy to answer any questions. If you want to send them to me through your host, I'd be happy to respond. Thank you. I have no disclosures relevant to this presentation. Patient care has historically been used to describe care delivery in a particular setting or location, i.e. in an outpatient clinic, and usually appointment-based, where patients consult with doctors who give specialist advice and treatment. It's largely delivered through appointments at routine intervals, with 135.4 million appointments taking place in England in 2023 to 24. Demand is increasing in part due to an ageing population and an increase in patient complexity, with an increase in patients living with long-term conditions and multiple comorbidities. The current approach often results in poor patient and clinician experience, including long waits to receive a diagnosis and/or treatment, poor communication, difficulty and confusion trying to navigate services, and follow-ups that are not aligned to patient need, low-value patient appointments leading to increased non-attendance. In 2025, we took a snapshot survey of Royal College of Physicians members, and 57% reported inadequate resources for delivering outpatient activity remotely. And additionally, 66.8% of physicians cited limited availability of rooms as a major constraint in providing outpatient care. Only 31.2% of respondents expressed having the time and information necessary to prioritise patients on waiting lists based on their risks. The need for care through outpatient services has grown year on year. This trend is predicted to continue as the population ages and more people live with multiple health conditions. These trends have contributed to growing waiting lists, and the majority of people currently on NHS waiting lists in England need an outpatient appointment rather than an operation. So in 2023, we embarked on a programme of stakeholder engagement to describe how outpatients could be or should be redesigned for the future. We held this programme over 4 summits in 2023. We examined some themes which we thought would be important and relevant, and some enablers which we thought could really unlock the future of outpatient care. During the summits, we engaged with a wide range of stakeholders, including patients, clinicians, colleges, specialist societies, commissioners, NHS England, and think tanks. And we got their views on how we could potentially enable and provide care better in an outpatient setting for the future, making it more sustainable. And so this year we've published the prescription for outpatients. This is a dual publication by the Royal College of Physicians and the Patients Association, and it is based on the output from the summits. It was launched as a response to the letter from Lord Darzi, his diagnosis of the current state of the NHS. It is a document with more than 40 recommendations, with all which are aimed at all people involved in delivery of planned specialist care, including patients. There's a QR code on this slide, and you can pick up the document if you follow that QR code. This infographic explains the nub of the document. We have tried to explore the purpose of planned specialist care, moving away from the term outpatients, because it does communicate constraint to both location and to appointments. We've tried to define 5 ambitions for reform, and we've explained this in the terms of 8 care shifts. I'll now explore these all a little bit further. So in trying to move away from the term outpatients, we really tried to define what were the purposes of planned specialist care. What are we really trying to achieve for patients in this setting? We felt that there were 6 main purposes of planned specialist care: advice and prevention, diagnosis, treatment and monitoring, pre-assessment for procedures and surgery, personalised care decisions, including shared decision-making, and ongoing condition management and support. In terms of the 5 ambitions for reforming outpatient care, the first is to achieve the best possible patient outcomes by ensuring that patients receive care in a timely manner according to their clinical need, and that care is delivered by the most appropriate healthcare professional in the correct setting, as close to the patient as possible. We know that this can unlock the best possible outcomes and for health and well-being for the patients. Secondly, we feel it's exceedingly important to empower patients in healthcare. We want to support patients to take an active role in their health by delivering personalised care, using methods such as shared decision-making and support planning and supported self-management to empower patients to be active participants in their healthcare. Again, there is evidence that this delivers more efficient outpatient care and also that it improves patient outcomes. We heard time and time again during the summits that communication was one of the areas which really needs to be improved and was a significant issue causing problems with patients' outcomes and their care. Communication to patients was often very poor. Patients often received notification of appointments, for instance, after the appointments had happened. They often received letters that weren't addressed to them about what had happened during an outpatient appointment. In addition, there were numerous examples of how poor communication between primary, secondary and tertiary care led to delays in care and poor patient outcomes. And we know that we need to address communication both with patients and across all levels of the healthcare system to improve patient outcomes for the future. We want to embrace innovation in order to deliver more efficient care. We want to deliver care in novel and effective ways that value patients' time and avoid unnecessary appointments. We also want to use innovative methods to ensure efficient and effective healthcare delivery. We also know that data and technology have significant promise to unlock improvements in both efficiency and in patient outcomes. We want to identify at-risk patients by using data and analytics to identify patients that are most at risk and use this information to appropriately prioritise healthcare. We also want to use data to help prevent health inequalities, as we know that leveraging data in addressing and minimising health disparities is possible amongst different populations. And we want to take a proactive approach to using data to prevent illnesses and complications before they become severe and involve significant healthcare utilisation. To achieve our 5 ambitions, we have described 8 shifts. These are from appointment-based care to a wide range of options for holistic care, from services that are difficult to access and navigate to simplified, timely pathways of care closer to home, from a one-size-fits-all approach to personalised care that truly meets the individual needs of a patient, from diagnose and treat to predict and prevent disease and complications, from teams working in silos to integrated pathways of care working across the healthcare system, from burnt out and disenfranchised healthcare workers to empowered and engaged teams, from counting activity to delivering the best possible health outcomes and patient experience, and from inequalities within healthcare to consistent standards of care. To deliver all this, we have made some recommendations, some for more immediate implementation, some for implementation in the medium term, and some longer term recommendations. And we've directed our recommendations to different groups of people, including the government, clinicians, healthcare providers, and system leaders. These are some of the key headline recommendations that we feel are some of the most important. We are calling on the government to reform outpatient care as part of their 10-year plan, and to deliver a robust, regularly refreshed NHS workforce strategy, to expand medical school places and specialty training, and to invest in administrative support and digital infrastructure required to provide the seamless, well-navigated care that we are looking to achieve. For clinicians, we are asking them to promote and implement new ways of delivering care outside of traditional outpatient appointments, to adapt a personalised care approach for all patients. Job plans must allow clinical time for activity associated with delivering modern outpatient care. So it must include, for instance, time to provide advice and guidance and patient triage. We're calling on healthcare providers to improve referral systems and self-referral options, to create easy to understand, accessible patient information, to adapt and implement digital tools like patient engagement portals, and to improve patient preparedness. For system leaders, we are calling on them to reform commissioning models to incentivise good practice and implement coding which can drive good practice through good data. To measure outpatient care value beyond activity numbers, taking into account patient experience and outcomes, and to evaluate novel and innovative approaches so that unintended consequences can be measured and addressed. If you want any further information about our programme of transforming outpatient care, if you want to tell us about your positive experiences or your innovations, we'd be really happy to hear from you. In addition, you can go to Medical Care Driving Change, and you can pick up some examples of innovative and good practice on that site too. You can follow the link at the bottom of this page, which will take you to our Transforming Outpatient Care page on Medical Care Driving Change. And looking to the future, I will be looking to explore opportunities to engage with your community to help integrate the recommendations, to assess the impacts, analyse the advantages, promote continuous improvement around these recommendations, and to share effective models. Thank you very much for your attention. Once again, I apologise I can't be with you, but hopefully we will be able to set something up in the future to take this work forward. And in the meantime, I'm very happy to respond to any questions, either via your host, or you can email me directly on teresa.barnes@rcp.ac.uk. Thank you very much.
Lovely, thank you. And what we'll do is we'll just pop a couple of links into the Q&A as we go through event as well, so that you've got those contacts as well. So that's brilliant. So it's a really big piece of work there that we've obviously agreed with the RCP to look at with our community on how we can actually take it forward back in our own organisations and systems. Literally got 3 slides here with just a few more examples for you, really, of changes to service models and delivery, really, just to give you a few more ideas from today to take away. But obviously there are so many more examples of what organisations are doing as well that we can learn from, that hopefully we can bring bring to the network and the community as we move forward. But you can see some examples here, and if we just move to the next slide, then just broken down the patient-initiated follow-up into a little bit more detail for you, so you can see both the benefits for the patient and our healthcare systems as well, and in particular that improved focus on the improved outcomes, really, because moving to this patient-initiated follow-up system really encourages patients to seek help when they notice changes, so potentially lead into those earlier interventions. There's a lot more of that collaborative approach to managing their health. And on the next slide, what we've done for you is just broken down integrated shared decision making a little bit more for you, so you can see the clear benefits there for both patients and clinicians. We touched on shared decision making on a number of days this week and the importance of it in terms of working together collaboratively with our patient and service users to really move health and care forward and help to improve those health outcomes. So just going to move on now because it's opportunity for questions. So anything that you want to pose to, any points that Chris has made, any points I've made, or any points that Teresa's raised in the prescription for outpatients presentation, or even wider around today's topic of efficiencies. So I'll have a quick look down the Q&A, but obviously if anybody wants to raise their hands, we can unmute you so that you can raise your question as well. Okay, so let's just have a look down. Okay, so Carl's raised a point here. To my knowledge, there are very few national clinical audits that focus on outpatients care, and thus data lacking in this area. And do NHS England, RCP or HQIP plan to address this, as it's a large majority of our patient activity, which it is. It's a really important area to look at in terms of efficiencies and trying to change the way that we actually plan and deliver health and care. So Chris, I'm not sure in terms of the national clinical audit agenda, if anything is looking to change on the horizon, or actually the focus on one or two national clinical audits that impact on outpatients and community?
Not specifically at the moment, and it's always challenging that kind of branching into the community, and it is an area that there are gaps. Carl's right there, and something that we can take forward and talk to NHS England about.
Yeah, that would be great. I know we've got a number of data platforms. I'm just thinking about the Federation data platform as well, where organisations have got their local data platform, they're linking in with their ICSs, their ICBs, and if we've not got the topics as you're focusing on here, Carl, in terms of those national clinical audits that are measuring a lot of that data at the moment, we can access and get that data locally, so that as we're starting to transform things on the back of this piece of work that the RCP are doing on the back of Lord Darcy's review, that actually there is data there. We've just got to look wider for how we can access it then to use it to help us to improve how we're reshaping health and care. But yeah, it potentially in that national clinical audit programme, it might be something that might need to be looked at. So yeah, Chris, you're going to take it back then, and I can certainly feed it in from an NQICAN perspective into our executive quality group clinical audit subgroup as well. Okay, are we seeing any more questions at all? I'm not seeing anything in the Q&A. I'm not seeing any further. Oh yes, Susan, I think you should be off mute and able to talk if you unmute yourself.
Thank you. Yeah, I'm just listening to the exchange that you've had just now and thinking that for a number of smaller trusts who are often in the position of being spurs to hubs for focused care, that those people, those patients, are our patients. They are within our geography. We see them for primary care services, we see them as outpatients, we see them for other reasons. And it does, I agree, it does seem there's a sort of quite a severe dividing line between whether you see patients for their primary condition and for active treatment, or whether you see them for therapies and outpatient appointments. Yeah, I think it's something that does need looking at.
It does, doesn't it? But I think we need to, we all need to be contributing to how we're going to reshape this. So actually we'll post today's event. Obviously I'm going to meet with Teresa from the RCP just to look to see what we can put on for our community in terms of more Q&A sessions and events, so that we can actually discuss how we need to take or support their piece of work, how we can take it forward. So yeah, there's a lot to consider, Thank you, Susan. So Carl, you got your hand up?
Yeah, sorry, I was just eating my lunch then when my actual question was discussed. So no, just to follow up on that, I mean, the presentation was very good, but it was lacking in data, and because we haven't really got any data around quality of outpatients care apart from some patient surveys and waiting list time and things like that. So the actual process of the quality of the consultations and whatnot is not evidence. That's why I was putting it in the chat about, you know, we need to have some better data to drive the improvements. So I'm not disagreeing with the recommendations from what was in the talk, because it does feel like that's what it is like in practice, but it's good to have data to underpin any improvement work, as we know, because that's why we're here, isn't it, this week, really, is to promote the use of data to drive improvement and making sure it leads to sustained improvement. I mean, one of the frustrations that I've heard is that people are now having more flexible approaches to where they get their care. And that's, you know, I had a relative this week where they went off and had a scan because it was quicker in a neighbouring hospital. And that was done very quickly, but when they came back to their own hospital to review those, that hospital couldn't review those scans because it was data not joined up patient care and patient record. It prevented, you know, so we had to do the scan again, you know, within that trust. So that's massive inefficiency and massive waste. So nobody from NHS England here, is there? But ultimately, we've got to try and sort out so that the patient has their own information, and then that can be shared with whoever they want, you know, because ultimately all of these this information is the patient's and not it's, you know, NHS, and I think that'll help things move along a lot easier in terms of information sharing.
Yeah, totally agree, Carl. I think, and this comes down to having that pure shared electronic patient record, but there's probably more capability within that NHS app then, isn't there, for us to all have access to our test results, reports, etc., that we've all got control of, and we can show to any clinician that we're accessing, any decision maker, where we need to have that shared decision making between us. So there's lots of potential, I think. But yes, yeah, we've not got NHS England on the call, but these are all really good things that when we work with the RCP, we can actually throw into the pot, and it can be taken forward with the right people that need to make the right decision, and we need to have the right money behind it, I think.
Thank you.
Thank you. Okay, one more question, then I think I'll go to Paul before we move on to announce our winner. Can you unmute yourself, Paul, to ask your question? You've got the ability to, so. Oh, it's Pauline, sorry, it's my view of your name, Pauline, sorry, your hand's up. If not, we could move on to the next slide, and then Pauline, if you're struggling to unmute at all, if you want to pop your question in the Q&A. And obviously we've got the opportunity to come back later to questions. So, okay, I'm going to hand back to Chris.
Thanks, Vicky. So it's my pleasure to announce the winners of the Clinical Audit Awareness Week Efficiency category. So the runner-up, the category this year is Laura Atkins. She's a tracheostomy lead nurse at County Durham and Darlington NHS Foundation Trust. And the project was 2347 tracheostomy standards of practice. I'll read out the judges' comments. They're good to see here. So it's good to see the cost savings in bed spaces, and also with an improvement in waiting lists for surgical patients due to this reduction in stays due to complications and freeing up bed spaces. Upskilling staff leads to more motivation and a wider knowledge base. Huge patient benefit in the short and long term with correct management of these devices. So congratulations. I'll now move on to the Efficiencies winner. The Efficiencies winner are Dr. Rahel-Ochido Odonde, Dr. Courtney Taylor, and Dr. Rachel Massey, consultant obstetrician gynaecologist, community and sexual and reproductive health, first-year trainee, foundation year 2 doctor at King's College Hospital NHS Foundation Trust. And their project was contraception after childbirth. And the judges' comments here were, this is a really excellent example of improving patient outcomes as well as reducing the risk of complicated pregnancies. Strong evidence base for this intervention with an ongoing uptake of contraception eliminates delays in primary care contraception prescriptions and gives patients education and a choice of convenient location. Education for staff and upskilling of midwives will improve efficiencies, has a great scalability and longevity, and gives women in potentially abusive situations a safe space and an early access to contraception. So I'd like to hand over to the winners to give their presentation.
Good afternoon, and thank you very much for having me and us. I am pleased, honoured and humbled to have the privilege of presenting this quality improvement project on improving the provision and uptake of postnatal contraception at King's College Hospital London at our maternity unit today as part of Clinical Audit Awareness Week. I am Dr. Rahel-Ochido Odonde, a consultant obstetrician and gynaecologist here at King's College Hospital London. I might have conceived the concept and project design, but the project would not have gotten to where it is today without the help of Dr. Courtney Taylor, who's just been introduced by Chris Gush, and Dr. Rachel Massey as well. Next slide. When we are looking at the importance of postnatal contraception, there are several things to consider. Unplanned pregnancies are common. Fertility can return as soon as 3 weeks after delivery. 1 in 13 women access abortion services as soon as 1 year following childbirth. 2021 saw the highest number of abortions in England and Wales since the Abortion Act was introduced. The coronavirus pandemic and fractured sexual health services led to poor accessibility. Since the end of the pandemic, access has not improved to pre-pandemic levels. The WHO recommends 24 months between a live birth and trying to conceive. And as a short interpregnancy interval is defined as less than 12 months, it carries an increased risk of poorer maternal and neonatal outcomes, which include preterm birth, fetal growth restriction, uterine rupture, and stillbirth. This definitely highlights the importance of postnatal contraception. Next slide. NICE has stipulated that we should be supporting women in making an informed choice about their contraceptive choices after childbirth, ideally within a week of delivery, to reduce the adverse effects of a short interpregnancy interval. Next slide. Our service here at King's aims to ensure that our women are given the opportunity to discuss their family planning needs at multiple points in their pregnancy journey. It has been well documented that maternity units are well placed to deliver immediate postpartum contraception. Contraception provided without much delay after birth can reduce the short interpregnancy intervals. This project focuses on the immediate post-delivery part of that journey, including on the postnatal ward, and ensuring patients have the opportunity to leave hospital with their contraception of choice. Next slide. We noted a lack of anecdotal in-depth discussions around postnatal contraception and a gap in provision of contraception following childbirth. The aim of the audit was to evaluate whether these discussions were being had and whether contraceptive choices were indeed being offered and delivered to those who desired it. This was compared to the NICE Quality Statement form. We evaluated the service provided by both midwives and doctors. We looked at the proportion of patients having both ante and postnatal discussions about contraception and if contraception was provided prior to discharge. We compared January 2024 with January 2025. Based on the NICE quality standard, 100% of patients who give birth should be given information about contraceptive methods by their midwife or doctor antenatally within 7 days of delivery and offered their choice of contraception method within 7 days of delivery. Next slide. The sample was composed of a list of patients who had a live birth at the Denmark Hillside of King's College Hospital within those 2 months that I've mentioned. This gave us 285 and 278 patients respectively. 2 retrospective data collections using EPIC searches, the electronic healthcare record software we use, were performed, and patient notes were reviewed. The software would expand the search to include related words. For example, searching with the word contraception would include notes with references to family planning. This raised confidence in the knowledge that the majority of documented conversations were captured. We did exclude home births and intrauterine deaths. Next slide. Rather than wait a year to make a change, I made a decision to start implementing changes whilst auditing data, trying to be as efficient as possible by using existing resources. I delivered postnatal contraception education, provided contraception on the postnatal ward, and established a new monthly postnatal contraception clinic held in the already established Maternity Assessment Unit, MAU. I already had a role within MAU as a supervising consultant. Dr. Taylor has provided support ranging from directing referrals, advertising, to implants insertions. The new clinic has been advertised and promoted through Instagram, mass emails, WhatsApp groups, and word of mouth. Referrals are taken via the MAU. Many have been pleased to hear that a new service is available, and there has been a lot of interest in learning how to insert implants. Next slide. As you can see, we are far from the 100% target. Only 5.2% of patients had documented conversations about contraception antenatally in January 2024, increasing to 7.9% in 25. Similarly, the proportion of contraception discussions and provision postnatally has increased from 8.4 to 12.9%. However, this is nowhere near 100%. And as you can tell, doctors are having most of the discussions. Unfortunately, there has been a decrease in midwife-led discussions. Both need to be able to have these discussions with patients because not all patients will have contact with doctors. Next slide. Overall, provision of postnatal contraception has improved. In both years, the hormonal coil proved the most popular form of immediate postpartum contraception, and most were inserted at the time of cesarean section. When given the option, outside of having a cesarean section, patients were opting for the subdermal contraceptive implant. In January 2024, we had no patients going home with one. Next slide. And since January 2025, we've actually inserted 15 implants in total, so one more since this slide was written. The postnatal clinic is once a month with 6 patient slots. It is there as a net to capture women who cannot get the implant before discharge. It is also being established as a clinic to train midwives and doctors to insert subdermal implants. The hope is that eventually the need for that clinic will actually become obsolete. Next slide. As you can see, there are several challenges that we have faced and are still ongoing. For each one, we have either found a solution, are working on one, or will be working on ways to address them. It was found that if we wanted immediate availability of contraception, there should be immediate access to the methods. Contraception stock is now available on the ward to ensure women can be supplied their choice of contraception in a timely fashion. Multidisciplinary teaching has made it clear that the responsibility of discussing contraception lies with both midwives and doctors. To ensure we increase the know-how and confidence, we are in the early stages of planning an FSRH essential course alongside carrying out supplementary teaching. Postnatal contraception is not currently funded by maternity services. We noticed when patients are signposted to GP or sexual health services, there was a high risk of loss to follow-up. Hence, making use of existing resources such as location, staff, and existing services, it was crucial in terms of my idea of weaving it in seamlessly for a better and more convenient patient experience and as low a cost as possible. In the bid to glean ideas and propose a London-wide solution to sustainable funding, I've been invited to attend London-wide postnatal contraception funding brainstorm sessions. I'm also part of a postnatal contraception national network, and this has been helpful in understanding different approaches others have taken in setting up their population-specific service. Next slide. Our model works on targeted staff education and a focus on reducing financial burden, utilizing existing resources. As already mentioned, we are organizing the FSRH Essential course on contraception following childbirth. I'm recruiting a midwife to train in insertion of subdermal implants. They will be a postnatal contraception midwife champion that can cascade knowledge and skills amongst other midwives, including those in the community. The aim is to have one implant fitter per shift. This will eventually eliminate the need for the implant clinic. We are designing a service evaluation looking at patient satisfaction and will target vulnerable and minoritized groups. And this will help us to attract and maintain long-term funding and sustainability. Next slide, please. So thank you so much for listening. And if you have any questions, Courtney and I would be very happy to answer them.
Lovely, thank you so much for sharing that. That's brilliant. So we'll open up the floor for questions then. If anybody would like to raise their hands, I'll just check to see if anybody's ready to pose a question. Oh, Layla. Okay. Yep, you should be able to unmute.
Thank you. Actually, it was just to say it was delightful to hear that you didn't wait for the audit results as such. You read the data as it was coming in and made changes. It's really great to have energy behind an audit and implementing a project so that you can then revisit with enthusiasm. So that was great to hear. Thank you.
Lovely, thanks, Layla. Layla's our London Network Chair, Regional Chair. Okay, we got any more questions? I'm going to revisit the Q&A. Okay, we've popped some links in there that you can see as well. Okay, we've got a comment in here, might not necessarily be for our, oh, there we go. I'll let you take yourself off mute and ask a question first, Carl, before I focus on this comment in the chat.
Thank you, Rachel. I think everyone else has been shy, and as I've warmed up already, I'll ask another question once there's an opportunity. So well done, great project. And like Layla said already, it's nice to see people reacting to the data and continuing a project and not just closing it and saying, here's my recommendations, is actually saying, right, we've done a project, we've identified a problem, we've got a solution because you've looked at all of them and carried on, and it looks now like you're getting good results. In terms of the category, you know, in efficiencies, can you explain to me a bit more around the efficiency side? Because I think, because you've got 15 interventions, etc., sort of thing. So is that scalable? You know, is it shareable? I'm just trying to think about, in terms of a generic audience, how we can learn more from what you've done, really.
No, thank you. That's a really good question. So I suppose I'm taking it back to what the key speaker was mentioning, Teresa Barnes, where you're changing how you think about service delivery, such as outpatient and planned specialist care. So from my point of view, we're meeting patient needs promptly. So however that looks for you in your setting, that's what we're doing. If you're thinking a woman, whoever has birthed a child, has a newborn, they're going to be so busy. So capture, you've got a captive audience there. So capture that captive audience or patient group and deliver the intervention that they need, because once they go off, getting them back is difficult, and funding is not there in the community with primary care providers to provide contraception and that 6-week appointment following delivery. There is so much that is being covered. It's just difficult. And by that time, 50% of women have already started having sex. And as we mentioned already, you can ovulate 3 weeks after delivery. So it's then too late. And a lot of people, because I provide late surgical abortions in complex women, actually are seeking abortions within that first year of having delivered because it was too soon for them to have a baby. So for me, yes, we're doing it in the inpatient setting, but it's efficient because it's not a bolt-on. We're just incorporating what should be delivered as part and parcel of, I think, maternity services. And within the 28-day duty of care, then also saying, whilst you're still under our remit, come back to us, let us follow you up and not pass you on, for a better word, to primary care. So I hope that's answered your question, but I think it's just finding quick ways and putting yourself in your patient's shoes and thinking, how can I make it as easy for them as possible? And in addition to that, focusing on community midwives, I'm now thinking about people who home birth as well, so that they have their baby, the implant can be put in the home. So it's just looking ahead as well.
Yeah, no, really good, and I like the point about when is this intervention going to be the most effective. So, like you say, you've got a captive audience, and it seems to be working well for you. Yesterday, I was at one of our own local presentations, and therapists were talking about their interventions being more towards the weekend because patients don't, the clinicians in 9 to 5, Monday to Friday. There's more time for patient therapy works at the weekend, so they're now doing their improvement project around starting therapy at the weekends and having more time, and the patients enjoyed it because there's things to do and got them out of bed, etc., and got people moving. So it is about trying to utilize the best moment to put in an intervention. So you've clearly done that. Well done.
Thank you.
That's brilliant. It's that making every contact count, isn't it? Okay, that's brilliant. Right, we've actually got a couple more questions coming to the Q&A. So Michelle's just asked, will there be any research in the removal of the implants, i.e. is there a large number when it is being done?
So I'm not quite sure I understand, is there going to be any research into it? Do we need to research it being removed? Because they'll then be able to access their local sexual health services to have it removed 3 years down the line, or whenever they would like to expand their families if they so wish. I'm not quite sure I understand the question.
I'll move to another one, and then Michelle, if you want to just type in if there's any more further clarification around there for a response. So Jordan's popped in, great presentation. Interested to know if there was much work done with sexual health services and teams. My organisation consists of one birthing unit, but then has several sexual health services at different locations. Was there a need to link in with services such as this, or was the aim to capture mothers before they had a need to attend these clinics?
So this work, because I'm very keen not to repeat work that's done before, is off the back of a doctor that used to work in the hospital and she was linking postnatal contraception services with our local sexual health department, but there wasn't a robust referral system. And so I decided to focus on the aspect that I had most influence on, and I'm developing good links with the sexual health side of things. And as you've noted, Courtney Taylor, she's a community sexual health reproductive trainee as well, and I know she's going to be in our patch for the next 6 years. So it's developing that relationship with her and then the rest of her team as well. So we're building on that. I mentioned I'm part of a postnatal contraception network. I know in East London, there's a consultant obstetrician who is dual qualified and works within sexual health. And so there, the postnatal contraception service is seen as a satellite service of sexual health, and they're the ones commissioning it. So it just depends on the makeup and the relationships you have within the area as to how a particular service is born. That's how I believe.
Lovely, thank you. Another comment in the Q&A here. So many women get missed to the postnatal period, and having these tools and access at the point of care instead of relying on follow-up appointments that may slip through the net is amazing. And I'm just going to scroll down just to see if we've got any more comments or anything coming through here. No, I think that's it. So not seeing any more hands. So really big congratulations and many thanks for sharing. And obviously you'll be working with HQIP to write the case study up and get it published onto the web pages for us all to look at in a little bit more detail anyway. So many congratulations, and a thank you to everybody that did submit their projects to this this category. Thank you. So I think we'll move on to the next slide now. We're almost at 1:30 and we are going to move to an evaluation. So if we move to the next slide, there's a QR code, and then we're going to do a little bit of summing up for today's event and Clinical Audit Awareness Week. But first of all, if you could scan the QR code, we've got a couple of questions about the session today, but also some questions around your key takeaways, the challenges that you're going to take away back into your own organisation. And once we've given you a minute to scan the QR code, we're going to pop it up onto the screen so that we can start to see some of your comments coming through. And Louise has also popped the link into the Q&A as well. So you need to click on it if you can't scan the QR code. I think that was a good information there. I think there was a little typo, but we know what that means. We do value your feedback. We do actually use it. We'll publish your key takeaway messages as well so that you can all see what everybody's taking away, because somebody might have picked up on something that somebody else might not have done. We all interpret information. We have a different focus, don't we, when we're hearing and listening the information that's shared. So yeah, good to look at the entire process, not just from the patients or with our service, yeah, which fits with the recommendations for our for taking health and care forward. So keep posting your comments in for us. We've got a challenge slide next, so I'm going to start talking about that whilst you're all popping in your takeaway challenges. Obviously, I talked earlier about that focus last year about being on that bold and ambitious, and us challenging you this year on value and impact and really questioning this project that we're now going to start. Is how's it going to add value, and actually how's it going to impact on improving health and care and ultimately health outcomes for our patients and service users. So we've got about 5 questions to challenge you with this year in terms of your thinking as you're participating in your national clinical audits, and you're also receiving your projects in for your local clinical audits as well. Actually really trying to put that 5-point question in there around how is it going to add value to patient outcomes, how is it going to impact and reshape health and care, listening to what matters most to our patients and service users in terms of driving those evidence-based improvements. And actually, as some of our attendees have just highlighted, what metrics are we going to use then to actually evidence the impact, evidence that we've made that difference based on what we've changed. And then actually, are we measuring across that patient pathway, across our system, working with our partners within our system? And then how are we actually effectively utilising clinical audit to drive a healthier future for all? So it's, I think Chris touched on it as well, around actually when you've got so many priorities to pick from, how do you pick the right priority to take forward? And sometimes asking some of these questions just helps us to reach that informed decision around what we resource and what we look at first. So more questions around questioning that value and that impact. So starting to see more questions, key takeaways coming through now, which is absolutely fantastic, and hopefully you've been reading them on the screen. So I'll get you to pop the slide pack back up if that's okay, Louise, but please do keep posting your takeaways in the evaluation. The evaluation is going to stay open for another week, 1 to 2 weeks. So if you've got colleagues that couldn't attend the call and then wants to listen to the recording and look at the slide pack, they can add their takeaways to the evaluation as well. Or ultimately, if we've had colleagues that have had to leave the call early, the evaluation will still be there for it to be completed, and we'll share the key takeaways. We'll publish those for us all. So these are the challenges I've literally just been talking to you about to take away from today's session. So I think if we just move on then, in the interest of time, then to the next slide. Brilliant. And just a quick sum up from me, and then I'm going to hand over to Lacey to give a quick sum up from HQIP's perspective on the week as well. So obviously massive thank you for joining us today and at all of our events through week as well. And reminder that obviously you can access the recording and slide packs for all of the events over on HQIP's web pages, and obviously the lunch and learns in addition on the NQICAN Future NHS Workspace. So please do share widely with your colleagues and take forward those challenges back in your own organisation. The week itself, in terms of summing it up as a bold and forward-thinking celebration really of how clinical audit drives quality improvement across health and care. And obviously the big campaign this week that celebrated our Clinical Audit Heroes, which I'm sure Lacey is going to touch on as well. It's recognising those individuals and teams that are really making that difference through effectively utilising clinical audit. And obviously we've got lots of colleagues that have joined us at the events that might not have submitted to the awards, but is obviously making that difference every day through their clinical audit and wider QI projects. So we've also had a call for action over on our Future Workspace to review review Clinical Audit Awareness Week. We've seen great numbers of interest in our events this week, so it's just at this point in time really to just ask you all to engage with us as we move forward over the next month or so and look to actually review Clinical Audit Awareness Week and what we want it to look like as we go into future years. If you're not a member of our Future NHS workspace, obviously, and you want to provide feedback, then drop us an email to nqi.can1@nhs.net and let us know your thoughts. But at this point, we're going to move to the next slide. I'm going to hand over to yourself, Lacia, to sum up from HQIP's perspective.
Hello, welcome everyone. So it falls to me to say a final few words from HQIP. I won't keep you long, I promise. It's been a long week for all of us and we really appreciate your time. I could share with you the corporate view of Clinical Audit Awareness Week. I could say there's been 140 award entries, 8 live events, 1,500 event attendees, etc., etc. But what I really want to talk about is to say how wonderful it's been to see everyone getting on board up and down the country, sharing the value of clinical audit. And particularly in these difficult times with stretched resources and ever greater pressures on the system, we really, really appreciate you taking the time to take part this week. But I do say this really not just because you're a sort of wonderful community doing great work, I'm sure you all know that, but really because of the value of that work. As you heard from Chris, HQIP truly believes that following the data is a pivotal part of balancing the NHS healthcare books, if I can put it in that way. I'm not sure I can do, I can do quote marks. I wasn't sure with my background, but you understand what I mean. And that means that we can direct resources where they will have the greatest impact. I mean, honestly, otherwise the resource versus care sum simply doesn't add up, does it? And so we look to and thank all of you for playing your part in that. It's been so important. I must say some thank yous, of course, firstly to Vicky, Louise and the NQICAN community, because they work so hard behind the scenes to pull this off, you would not believe, and we are ever grateful to them. Thank you to all the presenters, all the organisers and all the participants, without whom this campaign would not be possible, and in particular Drew Mark, who's been supporting HQIP over the last few months. We've absolutely, she's been so invaluable. Of course, I want to say thank you to all the award winners, all the excellent presentations coming in, but I want to also thank everyone for submitting a nomination. I mean, the calibre of entries this year has been the highest yet. You'll have to take my word for that, because I was one of the judges and it was unbelievable. So if you didn't make it this year, please do take part again next year, because we had an unbelievable calibre of entries. But I must also say thank you to the patients. I'm hoping we've got some patients on here today. We've certainly had some during the week, but they guide and steer us, if we let them, in getting this right. So after all, it is all about them. So thank you to all the patients who take part in our work. I'm going to sort of share with you very quickly a quick anecdote. I was lucky enough to go to a lecture by the godfather of AI, Geoffrey Hinton, if you've heard of him. This week I went on Monday evening. That's how dull my life is. But when asked what he thought was the greatest benefit of AI and data, he replied, improvements in healthcare. So I thought that was really, really insightful. It was just the #1 thing he said. So a Nobel Prize winning scientist is sharing the virtues of your work. I thought you'd like to know that. Finally, and I'll be told off if I don't do this, please don't forget to visit hqip.org.uk for all of the resources, all the recordings, all of the case studies, all of the articles, everything that we've put out there this week. And it'll all be there for you to share with all your colleagues going forward. So a final thank you from us. A thank you back to NQICAN.
Oh, thanks, Lacia. And thank you for all your support during the week as well, especially at the lunch and learns. It's been a true collaboration, hasn't it, throughout this week. So thank you. And I think if we move on then to the next slide then. So yeah, we've just obviously got our contacts here to help you continue to share with us what you've been doing locally, because obviously we say this every year, Clinical Audit Awareness Week isn't just 1 week in time. We need to keep this momentum going every day back in our own organisations and across our systems as well. So it's if you're not yet a member of the NQICAN Future NHS Workspace, please do go to the workspace and request to join. All of the Clinical Audit Awareness Week information is on our open section, and our discussion points around the 5 topics that we're focused on this week that remain really, really important in terms of quality in health and care remain open through year, and we want to see a lot more discussion as we're going through each day, each week, each month, and almost leading into Clinical Audit Awareness Week 26, because what we'll do is we'll listen to what we're learning and sharing together to help shape what future weeks look like as well. And for us, that Futures Workspace is really about networking and sharing together. We've all got so much to bring to the table in terms of celebrations and what's worked for us that we can then have that wider impact on as we're sharing it with others, but also bringing our challenges where we're actually finding things slightly more challenging to address, so that we can then learn from each other where somebody might have actually managed to have a success story around it. We're sharing some top tips then for making it better across the whole country. It doesn't matter where you live, you're actually receiving that good health and care on your doorstep. So that's ultimately the aim of that networking site. So please do join us. So it's a big thank you again for joining us. And I don't know if we've got another thank you. So yeah, we have. Here we go. A big thank you to everybody really for joining us. Huge thank you today for Teresa from the RCP, obviously Chris from HQIP and the rest of the HQIP team, and obviously the winners and the runners up, and obviously fantastic support from Louise, NQICAN's comm lead, and Carly, our webmaster, right leading up to the event as well as through this week, and obviously what you'll see coming out as well post-event as well. I think yeah, you just touched on the tip of the iceberg there, I think, Lacey, in terms of how much work actually goes into the week itself, and then obviously supporting through year as well. So massive thank you to everybody. Keep sending in your feedback. We want to know what impact Clinical Audit Awareness Week has had locally for you as well and across your system. So we want you to share what plans you managed to support throughout the week, and then obviously how you've managed to raise that awareness locally to how important clinical audit is for improving health and care. And then it's just to really flag at this point that the next NQICAN Open meeting is being held on the 9th of July, 10 AM to 12 PM, open access to all. The link will be on the Future NHS Workspace and also on NQICAN web pages as well if you're not yet a member on that Futures Workspace. So we'd love to see you join us. And at that point, I think feel free to put any comments in the Q&A, but obviously take care, have a good afternoon. And yeah, we look forward to seeing you networking with us going forward. Thank you very much, everyone.